right, everyone, thank you for joining us. We are now at 12:15 and it's time to start this edition of ETSU BMAT Echo. I'm Joyce Troxler, your facilitator. I am a family medicine physician and addictionologist, board certified in both, the program director for our Addiction Medicine Fellowship. I'm going to go around and have everybody take a second to introduce themselves, let us know your name and a little bit of your background, and thank you all for joining us. Anybody who joins us in after we get through with introductions, I'll just kind of go back around and pull everybody in to give them a moment to let us know who they are so we can thank them for being here. I'm going to start with Melissa Hood.
Hello, I'm Melissa Hood. I'm educational planner, previous educational coordinator for this program and many others with the CME department. And I'm happy to be here with you all. I do just want to make a note just to remind anyone to complete the evaluation, because the evaluations is what helps us plan our upcoming sessions for next year.
100%. And I found out that even if you've missed some, like, I don't know, from a year ago even, they're still good.
You have about a full year to complete them.
Yep. So if you've missed some, go back in. You can get them. Don't let those credits slide by. Kelly, if you can unmute and introduce, please.
Hi, I'm Kelly Moore. I'm an assistant professor and a licensed psychologist. I work in the psychology department at ETSU, and I'll be presenting today.
Yes, you will. Thank you so much for being here, Kelly. We really appreciate it. Brian, if you can unmute and introduce.
Hi, I'm Brian Clark. I'm the technology coordinator for ETSU CME. If you have any technology issues during the session, you can send me a chat or you can call the number on your screen.
Wonderful. Thank you, Brian. Cameron, if you can unmute and introduce, please.
Hi there, this is Cameron Heil, and I'm sitting here in a room with two other people, and I think that my speaker is going to backfire here. I'm a psychiatrist and also addictionologist.
Thank you for joining us, Cameron. There's about 4 of you in the same room that you're going to have a little bit of pain, but I can tell Veronica just stood up. The amazing thing with Zoom, like there she is, there she goes. Oh wait, she's back again because she just muted Tanya, who's not at her desk, so we'll get back to her. So Veronica, if you can unmute and introduce, please.
So my name is Veronica Van Ray, and obviously I'm pretty tech savvy to know what I needed to do. But I am a certified peer recovery specialist with the ETSU Addiction Medicine Fellowship, and I'm also a bachelor's of social work here.
Wonderful. Thank you, Veronica. It's great to have you with us. Kelsey, if you can unmute and introduce, please.
Hey there, I'm Kelsey. I'm a nurse practitioner working on the Help Sarah grant in the College of Nursing, and I'm also a UT Psych grad certificate program student.
Wonderful. It's good to have you with us, Kelsey. Thank you for joining. Rick, if you can go ahead and unmute and introduce, please.
Hello, everyone. I am Rick Wallace, and I am a librarian at the ETSU College of Medicine.
Wonderful. Thank you for being with us again, Rick. Rick is an amazing resource. You guys are going to see him throwing up citations in our chat box. Pay attention to that because you may want to get him to look something up specifically for you, or if nothing else, grab that information that he's showing us because he gives us links to some great articles. Richard, if you want to go ahead and unmute and introduce, and your peeps are on, so if you want to shout out and say hey to them, you certainly can.
Hi, my name is Richard. I'm an internal medicine resident from Norton Community. Here rotating with the Addiction Medicine Fellowship this month.
Great, thank you for being with us, Richard. We're really enjoying having Richard spend some time with us. Hanson S. or Hansons, you can unmute and introduce.
Hey, my name is actually Shannon Cook, and
yes, there we go. Hi, I thought you looked familiar. Hello.
I'm on faculty in the Department of Psychiatry. I'm an addictions medicine board certified psychiatrist, and so I'm happy to be here.
We are very happy to have you with us. Thank you for joining us, Shannon.
Thanks.
Anna, if you can unmute and introduce, please.
I am Anna Chalet, Medical Director for UT Family Medicine in Memphis.
Wonderful. You've joined us before. It's good to see you again, Anna.
See you too.
My little squares keep changing, so I'm going to ask Tanya to unmute and introduce since she's back.
Good afternoon. My name is Tanya Milam. I'm the medical assistant with the Addiction Medicine Fellowship here.
Wonderful. Thank you, Tanya, for being here. I'm going to change my angle for just a second because Cameron joined me in this room. There we go. Now we got him back on screen. Sudha, if you can unmute and introduce, please.
Hi, I'm Sudha Kumar. I'm an NP resident currently at the Johnson City Community Health Center. So I'm glad to be part of this Zoom meeting.
We are very happy for you to be part of this, Sudha. Thank you for joining us today.
Thank you.
I've got Kay Hefner next, if you can unmute and introduce.
Yeah, I'm Keith Hefner. I'm a behavioral health case manager with United Healthcare.
Wonderful, Keith. It's good to have you with us again.
Thank you.
Mateo Caffrey, if you can unmute and introduce, please.
In the chat, he says, I will be muted the whole time. So.
Oh, that's right. He did say that. I'm sorry. I actually saw that chat and then completely forgot it. He's from a VA pain clinic. Thank you for joining us. If you get a chance to unmute and shout at us a little bit, that'd be great. But otherwise, I totally get it. Just glad that you're able to join us at all. Erica, if you can unmute and introduce, please. Sometimes people step away and then they come back. We'll give Erica another chance to introduce. And I got someone waving at me. You can introduce yourself, sir.
Skylar Geller, I'm a fellow for 2.5 more weeks.
Quit counting. Thank you. Skylar actually will have our case for us today as well. Suzanne Fletcher, if you could unmute and introduce, please.
Sure, I'm Suzanne Fletcher, Dr. Suzanne Fletcher. I'm an internist and I work at Uninsured Recovery in Goodlettsville with my son.
It is good to have you with us.
Happy to be here, yes.
Yes, we're very happy to have you here. Excellent. All right. Oh, there's Erica. We've got video as well. Awesome. If you could unmute and introduce for us, Erica. Are you finding the icon, Erica, to unmute and introduce?
Yeah, sorry, I had to switch computers. My audio wasn't hooked up. My name is Erica Fugier. I'm the Director of Social Work and at LCSW over here at Catalyst Health Solutions. We're in OBOT Clinic.
It is really great to have you joining us, Erica. Oh, the Catalyst Clinic is one here that's in Johnson City, so it's so nice to have somebody from that office joining us. Thank you for being with us.
Thank you for having me.
Definitely. We hope to see you more. All right, I'm doing a quick sweep of our participants. I'm not seeing anybody else new. Anybody catches someone new and I didn't see them, let me know in the chat and I'll get you to introduce yourselves. Otherwise, Kelly, the floor is yours.
All right, let me go ahead and share my screen here. Can you guys see that? Okay, awesome. All right, so I'll be talking about justice-involved populations today, and specifically substance use within that population. And this is a group of people that I have been doing research with for the past 10 or so years. So I really enjoy talking about people that are in this population and some of the unique barriers that they face to receiving evidence-based care. So I don't have any disclosures to report. And the learning objectives for my presentation today will be to talk a little bit about the intersection or the interaction between substance use and legal system involvement, and also talk about the evidence-based approaches to treating substance use in this system and for this population, and the barriers that that people in this system face to receiving evidence-based care. So anytime I talk about people in the criminal justice system, I like to just frame the conversation around what our system looks like in the US. And so many of you may know that the United States has one of the highest incarceration rates globally. And what that translates to is that about 12 million people every year are entering the criminal justice system And that looks like about 1 in 37 adults that are under some form of correctional supervision. So that means they could either be detained in a correctional facility or under some form of community supervision, like probation or parole, living out in the community. And so we have a ton of people in the US who are cycling through the system. You know, they're getting arrested, going into the criminal justice system in some way. And we know that the vast majority of those people are going to be released from the criminal justice system. They're coming back out into the community at some point. So the idea that people go to jail and they never come out is just not true. What happens though is that when people do get released from jail or prison, we know that they have a really difficult time adjusting in the community and actually staying out of the justice system. So about 68% of people are rearrested within 3 years of being released. And that number just climbs the further you get. You know, you get to 5 years and it's 77%. At 8 years, it's something like 85% are rearrested and returning to the justice system. So people have a lot of problems successfully kind of re-entering the community and adjusting and obeying the law when they leave jail or prison. So substance use is a major factor in why people initially get involved in the justice system and then why they struggle when they get released from jail or prison. So we'll talk about that a little bit. What we know is that correctional facilities have sort of become one of the biggest providers of behavioral health care in general for mental health problems, substance use problems in the US. And when you look at the general population of people who are incarcerated in jail, so they're not in any sort of special medical unit or like the forensic unit, those people that are just in the general population of the jail, 80% of those people have elevated mental health or substance use symptoms that we would say are concerning. And looking specifically at disorders, like level of substance use disorder, about 63% of people in jails have an actual substance use disorder. When you're looking at state prison prisoners, that's about 55%, I think, something around like the mid 50s. But a really huge percentage of people who are involved in the justice system have a diagnosed substance use disorder. And compared to the general population, that is huge, a huge overrepresentation of people with substance use problems in this system. So how do people actually get involved in the legal system? How do people with substance use problems actually get involved in the system? Well, we know that there are a few different mechanisms that from substance use to criminal involvement. The first one I don't even have on this slide because it's just sort of common sense. You know, certain substances are illegal to possess and use. So if you have them or are using them, you're going to potentially get arrested. But other than that, there are a lot of different ways people can actually get involved in the justice system when they have substance use problems. So the first way is just through the pharmacological effects of the substance. So this is looking at, you know, the effects of intoxication and people doing things that are risky or illegal when they're under the influence of drugs. So we see this really commonly with alcohol, actually, which may not seem like it would be a substance that commonly leads people into the justice system, but it is, even more so than other substances, because we see people doing a lot of things like, you know, driving while intoxicated, getting into fights, being disorderly conduct and things like that when they're under the influence of alcohol. And another substance that we commonly see in the justice system is stimulant use. So people doing risky or illegal things when they're using stimulants. And the data shows that about 40% of people report having been intoxicated when they committed their criminal offense. So that's a pretty big, sizable chunk of people. So the other way that substance use can cause people to get involved with the legal system is just through engaging in criminal behavior to support their use or to get money to buy substances. So, you know, we see people who might engage in theft or, you know, shoplifting or other sorts of crimes like that to get things that they can sell to buy drugs or things like that. And then the third way is just, you know, using substances places people in risky situations, risky environments where they're more likely to be interacting with people who are engaging in illegal behavior and exposed to situations where they might have the opportunity to engage in illegal behavior. So we see that there's just this sort of environmental context that people are in when they're using substances that places them at risk for actually getting arrested and involved in the system. So that's how people can initially get involved in the justice system. But substances also place people at a higher risk of being rearrested and returning to that system. So we know that people who have more severe substance use problems are more at risk of relapsing when they get out of jail or prison and then being rearrested. So there's some nice data showing that sort of risk there. And then specifically looking at opioids, which has become kind of really been highlighted a lot in the research in the past 5 years. We know that substances pose a whole bunch of other risks when people are released from incarceration as well. And opioids specifically increase people's risk of having a sort of non-fatal or fatal overdose episode when they're released from incarceration, because they experience a decrease in tolerance during their incarceration. And then when they get out and use the same amount of opioids that they did previous to incarceration, they can often have an overdose. So the way that substance use problems are treated among justice-involved populations is really similar to the way that they are treated in any population. There's really nothing super special about people in the justice system that would make them really different from anybody who has a substance use disorder that would require some special sort of treatment. There are some unique aspects of the justice system that I'll talk about, but in terms of the actual evidence-based approaches, they're very similar to what we know works for other people who have substance use disorders. So we know that things like motivational interviewing, where we try and capitalize on people's intrinsic motivation to change and move them through the stages of change, help people, move through ambivalence about stopping drug use towards wanting to actually think about stopping drug use. So that's effective. That's been shown in studies to be effective for justice-involved populations with substance use disorders. Cognitive behavioral therapy for substance use is another treatment that's been widely used in the justice system that we know is effective, where you're teaching people how to recognize different thoughts that might cause them to continue using drugs, ways of thinking about substances that are not necessarily helpful or accurate, and then teaching coping skills for dealing with difficult emotions, right, that will hopefully help them not want to use substances to cope. So that's cognitive behavioral therapy. Other approaches that have been shown to work for justice-involved people are contingency management. I know we've had some presentations in this ECHO about some of these approaches as well. But contingency management is, using positive reinforcement. So giving people rewards when they're not, when they haven't used, when they have a clean sort of or a negative urine toxicology. And then medication-assisted treatment as well for things like opioid use and alcohol use. These are medications that we know are effective for people outside the justice system and inside the justice system. And the research with justice-involved people shows that methadone is the most effective for post-release outcomes, for keeping people from using illicit opioids and from having overdose experiences. And so there are a couple of other kind of specific treatment programs that have been researched for justice-involved people. So drug courts are programs that they're considered diversion programs. So when people get with substance use problems get arrested, they actually, instead of getting incarcerated and kind of going through the normal legal process, they're diverted away from incarceration and they're instead sent to a treatment program where they're still monitored by a judge and other people in the legal system. But really it's more about getting treatment rather than going and staying in a jail somewhere. So those programs are really, I think, gaining some popularity. They've got some good evidence behind them. And there's all sorts of treatments that are used within drug court models, right? Like some of them might use CBT, others might use contingency management, others might use kind of a mix of approaches. And then the last one I have on here is therapeutic communities. And these are a little bit more common in prisons than they are in jails because they tend to be specific kind of sectioned off areas in the correctional facility where people can connect with other people with substance use problems. It's supposed to be more of a therapeutic environment that's supposed to help people change. And there's some therapeutic communities that start when you're incarcerated and they actually extend into when people are released into the reentry period. So those have some really good evidence behind them as well for helping people refrain from using substances. So those are all really great treatments that we have available for people in the criminal justice system who have substance use problems. However, the research is very clear that most people who have substance use problems in the legal system do not receive any sort of behavioral health services whatsoever. And also they're even less likely to receive services that are evidence-based. So I wanted to spend, the last part of the talk today addressing some of the barriers that impact substance use treatment in the justice system. So it's hard to talk about people who are in the justice system and who have substance use problems without talking about stigma. It's one of the biggest barriers to providing effective treatment for this population. And so when we think about stigma, this really is just referring to having any sort of attribute that people or in society judge or devalue. They judge negatively or devalue. So substance use is definitely one of those. Having a criminal record or criminal involvement is one of those. And there are all sorts of other attributes that are judged negatively as well. But people who have substance use problems and who are justice involved are particularly stigmatized in the US. So some of the common stereotypes that people, including healthcare providers, have about justice involved people or people with substance use disorders are that they're dishonest, they're untrustworthy, dangerous or violent, that they have no self-control, that they'll never change, they're unmotivated to, work a regular job or unmotivated to stop using drugs, that they're manipulative. There's, the list kind of goes on and on. A really big one is that they're immoral, bad people. And, these are stereotypes that might seem like, you might think that not a lot of people have these thoughts, but it's actually more common, I think, than you might think. And there's been a lot of data showing that healthcare providers in particular have a lot of these thoughts about people who use substances and kind of expect their patients a lot of times to never change. And it's easy to see where that comes from, right? Because you see people who day after day aren't getting better. And so it can be easy to develop some of these thoughts, but these are just considered really, the negative stereotypes about people who have substance use problems and who are justice involved. And the stereotypes are worse for certain groups, like women, pregnant women, parents, people who inject drugs, and people who commit sex offenses. The stigma tends to be more severe. The stigma is a barrier that actually impacts many different levels of care in the justice system and prevents people from getting effective substance use treatment. So we know there are structural barriers, which are just referring to policies or laws that really restrict, access to care for the stigmatized group. So certain medications and other sorts of treatments for addiction are not even offered in the justice system, and probation officers, for example, might not even refer people to treatments that are effective. So there are some structural barriers there with the limited access to treatment. And there's also the social piece, which I mentioned just a moment ago, with a lot of times when people with addiction problems or substance use problems who are justice involved go to seek treatment, they oftentimes feel really looked down upon by providers, and they feel like people are annoyed and don't want to talk to them and don't want to help them and don't think they can change. And so there's this piece of not wanting to engage with treatment that people experience pretty often when they get out of jail or prison. And then there's all sorts of, cognitive and emotional experiences that stigma can cause for people, like anxiety, stress, depression, shame, and the resulting kind of avoidance and withdrawal that they experience. So these are all barriers that uniquely impact justice-involved people who have substance use problems and are very big barriers to care in this population. So just a little bit more about some of this, switching away from stigma for a moment. I did a study a couple of years ago that looked at different reentry programs addressing substance use and just looking at, the extent to which programs were providing evidence-based substance use treatment. And we found in this review that out of 34 studies that met our criteria, 21 of those studies showed that the program provided some sort of substance use treatment, that the justice system provided it, whereas 13 of them just connected people to treatment and didn't provide any sort of substance use treatment to people while they were in the justice system. And then the 21 programs that did provide treatment, only 12 of those provided any sort of evidence-based treatment, such as motivational interviewing or CBT. And I think a couple of them were therapeutic communities. So we're seeing that, a lot of times the justice system is acting as a coordinator of care, like they're connecting people to treatment when they get out, but there's not necessarily a lot of treatment happening during while people are in the justice system. And then the treatment that's being provided isn't always of high quality. And some of the reasons for that have to do with the cost of services, staff in the justice system not having adequate training to provide certain types of evidence-based substance use care. And then there's, stigma kind of creeps in again for certain types of programs like contingency management. And I know this isn't unique to the justice system, but criminal justice staff really believe that we shouldn't be giving any sort of reward to anybody for staying, not using drugs, because basically they should be doing that anyways, is the sort of belief that people have about some of these approaches. And thinking specifically about medications for opioid use, because they're kind of unique in that there's a ton of stigma around these medications, specifically in the justice system. There's been some studies showing that prison and jail administrators just don't believe that they're effective a lot of the times. And then there's all sorts of regulations around the use of these sort of medications in the justice system that makes it really hard for them to be part of the standard care. So there's, regulations around having to obtain sort of license statuses for distributing methadone and things like that. Concerns about diversion of medications is really big in the justice system. So people, staff members in the criminal justice system often don't want people to be, diverting their medication or giving it to anyone else. And so they just don't want it at all in that system. And the final thing I wanted to mention that I think is kind of unique about working with substance use within the criminal justice system is around motivation for treatment. So people who are justice involved often get connected with substance use treatment in a way that is not necessarily like they're volunteering for it. That's not always true. Like sometimes when people are in jail and prison, they are seeking out treatment programs while they're there and wanting to do something with their time, because they've got a ton of downtime. So they figure like this would be a great time for me to work on these things. But oftentimes what happens is people are sort of mandated to do treatment when they get out of jail or prison, and there's a stipulation of their probation. So there's this idea that it's they're being kind of coerced, that if they don't do treatment, they're going to get incarcerated. And so there's been a lot of research on, is this really a good idea? Should we be using legal coercion to get people connected into substance use treatment? And overall, the consensus is yes, it's better than them not doing treatment at all, and they do still get some gains out of substance use treatment, even if they're being mandated to it. So the consensus is it's better to mandate people to treatment than to not have them do it at all. And a couple of the things that tend to make people more likely to engage in mandated treatment is bigger consequences for not going, so longer incarceration time if they don't go, and then having other sorts of things that they care about, like family court cases and other things kind of pending the result of their treatment engagement. And the people who are most at risk of not engaging in mandated sort of substance use treatment are younger people who are incarcerated and people who identify heroin as their primary drug of use, as well as people with a more extensive criminal history. So the last point that I wanted to make is that when thinking about how to provide effective substance use treatment in the justice system, we have to remember that the system is fairly complex, and there are a lot of different points that people, a lot of different sectors that people move through when they are in the justice system, starting from when they're first arrested to when they actually get incarcerated and then get released into the community. And so there's a lot of different points at which we can provide effective substance use treatment, and which treatments we provide really should be tailored to the specific circumstances at each of these points. And this is on this slide it's called the sequential intercept model, basically showing points in the justice system at which we can insert evidence-based care and sort of the unique aspects of those different points in time. So in conclusion, people who use substances are highly likely to get arrested and be involved in the legal system at some point, whether it's just from possessing those substances or having other sort of interactions with the legal system. And while we have a lot of effective treatments for people with substance use disorders that have been shown to work specifically in the justice system, there are a whole lot of barriers to actually providing care within this system that need to be addressed. All right, and that's all I have. So if anyone has questions, I'd be happy to answer them.
Wonderful, Kelly. Thank you so much. That was a fabulous presentation. I really liked the slide at the end. And I don't know if you guys picked up on this, but I think one of the studies Kelly referenced is actually hers. And as I told you, Rick would be putting up citations in here for some really great articles for us to read. And one of them, I believe, is Kelly's. It may be the one that you referenced in your slide deck as well. It's actually the second one that Rick gives us. So make certain you guys grab those. These resources should also be included on our resource page on the website. But there's some good articles in there. The one that Kelly wrote, actually, effectiveness of medication-assisted treatment for opioid use in prison and jail settings, the meta-analysis and systematic review she was talking about. But there's a number of good ones in there that Rick has provided us, including one that includes juvenile drug courts. So grab those. We do have a couple of people who've joined us, and I skipped over introducing our friends in Norton. So if you guys have questions, be formulating those while I get Katie Langley to unmute and introduce.
Hi, my name is Katie Langley. I'm in ETSU Psychiatric Nurse Practitioner Program.
Fabulous. Thank you, Katie. It was good to have you joining us. And
Thanks.
Michael Reynolds, you've joined us as well.
Yes, I'm the project director for Centerstone's medication-assisted treatment program.
Great. Thank you for being with us again, Michael. And then the auto LTC NU 42, et cetera, that is the Norton internal medicine program, the Norton Community Hospital internal medicine program in Norton, Virginia. So thank you guys for joining us as well. Questions for Kelly before we move into our case presentation?
Kelly, this is Skylar Geller. On the population that you've evaluated that have been directed to engage in care versus voluntarily engaging in care, do you have some specific articles or information on what % of those are successful in recovery, as in not re-entering the criminal justice system and maintaining therapeutic relationship?
Yeah, you know what? I don't know that offhand, but I've read studies that are getting at that look at retention among people in court mandated programs. I can't remember offhand what those stats are, though. I know if people are going to drop out, it's most likely to happen in the first 90 days. And that if people engage within the first 30 days after being released, it's really likely that they'll stay in, but I don't know exactly what percentage complete. And, you know, it really depends on the type of program. I think like here in Tennessee, some of the programs that people are mandated to for substance use are like a year long or 2 years long. And people tend to really struggle with completing programs that are that long, that interfere with their ability to work, because sometimes the programs have services that have to happen during the day. I know that it's different depending on like the length of the program and the intensity, but I can try to dig some stuff up and send it around.
Thank you. I have had some pretty good longitudinal, just anecdotal study of patients in recovery court here in Washington County, as well as Judge Sloan's court in Dandridge. And as you said, it's a long period of time. They're frequently in there 18 months, but most of them are engaged in work. I mean, they've got them in halfway houses and finally out into their own apartments working.
Oh yeah, and it really depends on the type of program. Like Judge Sloan's program is like a model program that's really excellent and has really good therapeutic environment. Not all programs are like that one. So I think that really impacts whether people stay engaged. But yeah, drug courts I think do have a pretty good success rate, but I don't actually know it offhand.
And with that, Skylar, you're right there and you've been talking and I have shared, I hope, your case submission. Okay, good. Brian's nodding at me. So if you want to go ahead and jump into your case and give us a quick synopsis. It doesn't always have to be this way where our case matches our presentation, but in this situation, we do have a case that has criminal justice overlays to it. So Skylar, if you could please tell us about your patient.
Certainly. This is a little bit different case. In our patient population, we meet many clients who are on probation, facing criminal charges, or are out post-criminal incarcerations. But this particular patient is, I think, somewhat illustrious of what we as addiction medicine clinicians can do to assist our patients who are in a criminal justice system involved. This patient is a 26-year-old male, presented to ETSU Addiction Medicine by way of an inpatient consultation, had a seizure and had a prolonged post-ictal phase, was in the ICU and then transferred to the ward where we saw him. This patient had a significant history of substance use, opioids since age 13, 10 years of ecstasy, 7 years of benzos. Actually had to discontinue his ecstasy due to a myocarditis, which, as we know, people tend to substitute one drug for another, and he increased his benzos, which were Xanax short-acting benzo, to the 20 to 30 milligrams a day range, and was pretty well stable on buprenorphine as the only opiate. No, I'm sorry. No, he was on roxycodones, 60 milligrams a day of roxycodone. So medical history, had sickle cell trait, vitiligo. I told you about the myocarditis and this seizure. No surgical history, psych history of anxiety, depression, has somewhat chronic suicidal ideation without plans and no attempts. Significant trauma history, gang activity, long involved in the substance use communities. His mother was a polysubstance use abuser. His father was found dead in a dumpster. He's been in foster care from 4 to 18 when he wasn't in juvenile detention or afterwards in jail. He's a native of New York and had relocated to this area. He's on probation in both New York and Tennessee. He and his baby mama have lived together for several years, has I believe a 6-year-old as well as a newborn and a stepson who is older. This newborn is kind of the crux moment in this patient's life. He decided that he needed to be a better father, be a better person. And so he abruptly stopped his 20 to 30 milligram a day Xanax habit, as well as abruptly stopped his 60 milligram a day roxicodone habit. And as described, he ended up in the hospital with a severe withdrawal seizure. Started on Suboxone in the hospital for his opioid withdrawal and began a taper on Valium for his benzo use disorder. Came into our clinic and followed pretty faithfully. However, he again decided to acutely taper much more aggressively than we had recommended and ended up in our clinic needing a couple liters of IV fluid and some IV Phenergan to be able to function. However, that did give us a little shorter time on his withdrawal or his taper. Our hard stop was a June 4th 90-day incarceration that he had pled to just after he left the hospital. And it was clear when he came in after trying to more aggressively taper his benzos and buprenorphine that we weren't going to make that target date. So we contacted his attorney, and the initial contact just was verbally that we were going to need more time. A letter was drafted, and that came about 6 hours, 6 or to 10 hours after the initial contact. Apparently, after the initial contact, the attorney and the DA had met. DA had no problem. However, the judge said absolutely not. The letter arrived, that was reviewed by the DA and the judge, and we were able to get another 4-week extension on his 90-day with the specific words, quote, "I don't care if he's in the hospital, he must arrive at the jail on the 22nd of June. So I think the illustrative point of this particular presentation is the effectiveness of those of us who treat patients with substance use disorder to engage the systems, and in this case, the criminal justice system, in a direct and factual manner. And I believe that has significantly impacted this particular criminal justice involved patient. And I'm certain that we will get him withdrawn from his benzos and his opiates. Just as an insurance policy, started him on Depakote as well. And plan on seeing him tomorrow morning at 8:20.
Thank you, Skylar, for sharing that patient with us. I'm just going to have a really quick wrap up of him. 26-year-old gentleman who has history of opioid use disorder and benzo use disorder that followed on the heels of MDMA that had some physical complications, cardiomyopathy. I'm just going to toss this in from what I remember from the case. He did have a repeat echo, and apparently things had improved since he had ceased his MDMA use. Seized secondary to abrupt cessation of his short-acting benzo, stabilized him with some buprenorphine and Valium, working on a taper, knowing that we had a short period of time to get him to a 90-day sentence safely. And then we had the opportunity to advocate and extend that time frame so we could get him safely off of medications and he could be in the jail and not do dangerous things in a jail setting. Did I summarize that okay? Any clarifying questions for Skylar on this case?
I had a question. So the jail would not continue the taper? That's why it had to be done before going in, or they were going, that part of it?
No controlled substances in our penal or our Department of Corrections in Tennessee. There are Department of Corrections that actually will keep people on opiate agonist therapy. We do not happen to be in an area that does that.
I have a question for you because I've had to do something very similar many times at the VA with patients who basically decide they want to leave an alcohol withdrawal treatment bed too fast. Like I think they're going too fast. So I'll put them out, I'll send them out on Valiant, Depakote, Valproate, or maybe sometimes gabapentin. Did you bother to look, because I haven't looked in probably 3 or 4 years, for any good literature on how protective the anticonvulsants are in a case like this, where you know they've had a short-acting benzo, and then they had pulled, and then they had a seizure? Because I could never find anything a few years ago when I looked.
This is as the equivalent of buying insurance at Vegas.
Yeah, right. Yes.
Other clarifying questions for Skylar on this case? Other thoughts or observations?
Did just want to say that, oh, sorry. Do you want to go?
Sorry, I had a question. Well, I just wanted to kind of clarify because I come from a different jurisdiction because I'm from Florida. So if this patient was arrested, you know, and he's going to abruptly withdraw, right, from the Roxy and the benzos, and he probably would have had a seizure, right? I mean, it's safe to say you incarcerate him, no substances, seizure, then he goes to the hospital, and then he detoxes there. There's basically not I guess I don't understand what would have happened if you guys weren't involved and didn't do this kind of outpatient taper prior to going to jail, if he were to stay in that jail environment, but a taper wasn't available.
I think it is clear that both alcohol and benzo withdrawal should be under medical supervision, as those are the two withdrawals that are potentially lethal. You're very uncomfortable with opioid withdrawal. Well, you're miserable with opioid withdrawal, but it is unlikely to lead to a fatal outcome. That is not true for benzos or alcohol, and therefore not being involved, if medical assistance is not involved in that is not in anyone's standard of care, and the criminal justice system would find themselves criminally liable for that if they did not seek medical attention. In the past, there has been a great deal of impunity within the criminal justice system for inmates who die in custody. I think that tide is turning.
And I can also speak to that. I know that well, I won't say it's common, but a lot of correctional facilities will provide medications for opioid use specifically for taper purposes. I don't think that's necessarily the standard in Tennessee, but some facilities, there was a study that is outdated at this point. It was in 2005, looking at which sort of jails and prisons provided medications for opioid use for taper purposes specifically. And at that point, it was like half, I think. And then I think, the rates were higher for pregnant women who were going through withdrawal from opioids. But even this is one of the biggest problems with providing substance use treatment in the justice system. There's just I think it really boils down to stigma. A lot of times there's a lot of just unwillingness to provide these sort of medications. There's a belief among people in the justice system that medications are actually, just allowing people to continue to get high. And so, the idea is that people should go through the withdrawal when they get arrested. So that is changing. I know in a couple of different jails here in this area, we're starting to provide some medications for opioid use. Judge Sloan is leading some of those efforts. But yeah, it's not the standard of care to provide that a medical taper, or to provide that for people with opioid use, who were on those medications previously before getting incarcerated. They just often can't get them when they're incarcerated, which causes a lot of problems.
Cameron?
And I think that this is a common problem among the people, even in the society. They do not really know that how dangerous is a person that is coming off of the alcohol or benzodiazepine. For this case, of course, the criminal justice system, some people start knowing and getting information and increasing their knowledge about what medical complication can come with someone is abruptly stop those use of those substances. But it's not common to know, it's not a common knowledge for everyone. And that's why we see lots of people, even, not in a criminal system, when they don't have access to this kind of substances, they abruptly stop it and they ended up to have some complication. And as Dr. Geller says, that sometimes the cases is very, tragic outcome on that one.
It does happen where someone is in a facility and they're going through withdrawal, and they'll be put into a solitary confinement type situation. And so there's no one to watch over, there's no one to see what they're doing. They're not getting the medical attention they need. And so in the letter that Skylar sent to the judge, he used the F word, fatal. And I think that's what got the judge's attention, because that's unfortunately not an uncommon occurrence where someone's condition is not properly identified and managed, because there is this sense of just lock them up and let them sweat it out. And then, we'll be over that hump. And again, that, because we don't have appropriate, most of the time, medical support in these facilities to recognize the danger that these individuals are facing. And so you will have someone, when they go and check on them and see if they're okay, they're not okay because they're dead. So.
And if I may add just a little bit on the other side of things, to Kelsey, to kind of answer your question a little bit, what would have happened to him is simply what happens to I've been on that side of it. I've been in the side of the person detoxing and withdrawing. And the unfortunate thing in the state of Tennessee is that it's, and in a lot of areas, we have this unfortunate good old boy system going. And so a lot of things get mislooked and kind of swept under the rug, I feel like, something that people are practicing outside of, they're not medical doctors. For instance, you have these correction officers that are making calls that they shouldn't be making. I personally witnessed people in severe alcohol withdrawal having hallucinations and everything, and literally laughing at that. It's barbaric is what it is. But I am on what a wonderful presentation that you gave, because it is showing that there are people paying attention now and really trying to get in there and do the research and what is evidence-based and what is going to be what's going to help people, because it's I watched a documentary not too long ago on how jail systems are just mental health systems anymore that aren't equipped to handle it. So I'm just grateful that our doctors here were able to help this individual, because I think it would have been a brutal outcome if he didn't.
Yep, I totally agree. Michael, you shared a couple of things in chat. Do you mind sharing with us what that is that you shared with us?
Yeah, I actually work with one of our local recovery courts, and we recently had a visit from the National Drug Court Institute. And just looking up on their website real quick, they had about 60% graduation rate for participants. I know personally with our recovery court, our graduation rate is kind of low, but of those people who complete the program, they stay out of jail for the next 2 years about 80% of the time. So, I mean, if done properly, recovery courts can be very, very, very successful. And so that's my little soapbox for today.
Thank you for sharing that with us. And guys, you can always share stuff with us. I love it when you put stuff up for us, because we learn from each other. So thank you for doing that very much, Michael. It was actually a huge, good feeling. I think all of us had in clinic when Skylar got the response back from the judge that we were going to be able to offset his turn myself in date by another 4 weeks. Our goal being to have him completely withdrawn from his medications so that he had some time off of them. So it's not just like, okay, we're done, go in, I hope it's going to be okay, but that we're going to have a few days, maybe 5 days, I think, with the way that Skylar's written the taper, free and clear of any of the substances, so we know how he's going to do. And then the Depakote was brought on board with the idea of, if we still have a little bit of twitchy, electricity happening in that brain from the Valium being gone, I think honestly we're in a really safe place with the Valium that we're using, the taper that he's doing, but just adding in some Depakote and also having something that they should continue when he goes into the jail. So it's a pre-existing medication that we can say, he'll have the prescription saying it can be continued while he's there. That's what we're hoping will happen from there. One of the other really amazing things we're going to get to do, because we have Veronica on our team, is she goes out and meets people where they are. So during those 90 days, he's got a visitor right there with Veronica. So we're going to go check on him in the facility. Because having contact with our patients, knowing what's going on with them, makes us more effective in getting patients to a place where they feel, our patients and clients, where they feel like they can share this information with us. We've also had a recent experience with the patient and some of her dealings where we found out a little too late, like what the real story was. Like we could have been so much more effective if we had known what was going on earlier. But we meet our patients where they are. And so the one that we didn't know enough early on to be as effective as we could have been for her, a learning point for all of us, including the patient, that actually these guys will advocate for me. And then when our patient does go and turn himself in, we will be there for that. And so that we are also there when he is released, forging those connections and making certain they know that we're there beginning, middle, and end, and every single stop along the way. Any other comments or thoughts before we part company for today? Because our hour is drawing to a close. Wonderful discussion as always, guys. 2 more weeks. We'll see you back here. We are about to wind down. I think we've got 2 more sessions to go. I just know our last one is July 7th. So I look forward to seeing all of you next 2 weeks and 2 weeks after that. We'll take a short break. I'll keep reminding you of this, but it's a break. It's not the end, and we will be back. Calendars will be developed, shared, and I look forward to seeing you guys to finish out this series and in series number 5. All right, everyone take care. We'll see you again.